Good morning, everybody. What a great audience. I don't even say anything, and you clap. I love this. So I'm going to make sure I can figure out how to work this. Excellent. I wanted to talk a little bit about the clinic to let you know what we have there. And then I was going to review some of the basic information on nerves, myelin, and the axon portions of the nerves. So at the University of Washington, we have a number of providers. We have 5 neurologists, 4 are neuromuscular trained, and we have 1 neurogeneticist. We have a rehabilitation medicine doctor, and we also have individuals doing research and have for a number of years. In addition, the specialists include available there are our genetic counselors and then the therapists, so physical therapy, occupational therapy, if indicated, respiratory therapy. There's an orthotist, orthotics clinic not on site, in addition to the nursing support and the staff there. Great group of people. And we meet on Wednesdays on the 8th floor. Also, part of evaluation involves electrodiagnostic testing. That's the nerve conduction study in EMG. And that's also incidentally on the same floor. And laboratory tests are indicated in evaluating for other causes and also for confirming genetic mutations that would confirm a certain diagnosis. The Center for Precision Diagnostics is a newer entity. They're doing a lot of the genetic tests there, and that's the lab. It's not a clinic, but it also gives us access to a lot of knowledgeable people as far as doing testing. And for neuropathy, they have a 92 gene panel, and those aren't all CMT, of course. The CMT Center of Excellence includes individuals with clinical expertise that do comprehensive evaluation and then care. As I mentioned, we have a lot of different specialists and providers available to make this a multidisciplinary opportunity. And the Inherited Neuropathy Consortium is an international patient registry that we've been involved in as well, and getting as many people as are interested, but as many people available to be at the forefront of times when we have treatment available, and also to meet each other and teach us as well as learning from us. And this is the listed under the clinicaltrials.gov. Those are that's the site that lists all the different clinical trials available. And that's a registry. Is that enough time? How about that? If you remember, just clinicaltrials.gov, that would get you to that, and then you can search for CMT. So Charcot-Marie-Tooth disease is named after 3 neurologists. Jean-Martin Charcot, Pierre-Marie are French neurologist, and then Howard Henry Tooth is an English neurologist. And those were the individuals that first identified the disease and described it. So talking about the peripheral nervous system. So the peripheral nerves carry the impulses from the spinal cord to the muscle. And the peripheral nerves will convey sensation, so things like pain and temperature, position sense, from the feet and the hands up to the spinal cord and then up to the brain. They're also involved in balance. It's important to know where your feet are in space in order to be able to balance. And in addition, the feed down loop, the brain tells the limb to move, and then that goes through the spinal cord and then down into the peripheral nerves. And when the peripheral nervous system is damaged, what we see is problems with all of these things. So weakness, muscle loss, problems with balance, and impaired sensation. So this is comparing a wire, essentially, which has the inner core, which is like the inner neuron in here, and then it has an insulation, and that's what the myelin around the nerve does, and it helps improve conduction speed. Myelin is this layer of insulation around the nerves, and it enables them to conduct the impulses very efficiently from the peripheral sensory receptors to the spinal cord, and similarly from the spinal cord out to the muscle. In the peripheral nervous system, the myelin is made from Schwann cells, which are pictured there. And myelin is made up of a number of different things: proteins, lipids, which are fats. And one of them, pertinent to Charcot-Marie-Tooth disease, is peripheral myelin protein, PMP22. This is a cartoon of where the pathways is, so you can visualize it. So when you feel something in the foot, it travels up to the back part of the spinal cord and then goes through pathways up to the brain. And the front part of the spinal cord, the impulse will, we use the term synapse when it goes from one nerve portion to the other, and then that will control the muscle movement. And the individual nerve, if it's taken apart, you can see the individual nerve fibers and the individual neuron itself with the myelin around it. And when damage occurs to the underlying nerve, it's referred to as an axonopathy. Axon is the underlying nerve. And when damage occurs to the myelin surrounding it, it's referred to as myelinopathy, and we see different things as a result of what areas of the nerve are affected. The bottom image on the right is a cross-section of the nerve, so if you cut across that, and then here we see the individual axons, and the myelin around them isn't depicted very well, and these are our blood vessels. Peripheral neuropathy affects about 5% of the U.S. population, and overall, across the world, more than 15 million people. The hereditary neuropathies make up affect about 36 individuals out of 100,000, and have a projected prevalence of about 108,000. That would be per year. Charcot-Marie-Tooth disease is one of the hereditary, or many of the hereditary neuropathy group, but one portion of the hereditary neuropathies. And it affects about 150,000 people in the US, which is about 1 in 2,500 individuals, and worldwide is 2.6 million. It will affect all races, genders, ethnic groups. It is very rarely life-threatening. It is not something that affects your intelligence, your brain function. And it's usually passed down from generation to generation. Currently, it's not curable, although we do have some treatments, we say, coming down the pike, possibly for approval soon. There are more than 80 different genes associated with Charcot-Marie-Tooth disease. When individuals with Charcot-Marie-Tooth present initially, what we hear and we see is muscle weakness, muscle loss, and we use the term distally, so furthest from the core. So it would be down in the feet typically, and then it can as it progresses over time, can affect the hands as well. Terms such as pes cavus is referring to high-arched foot, hammer toes, stork leg appearance or inverted champagne bottle. I like that one. Individuals have impaired sensation, and one of the things that we see commonly is decreased reflexes. Typically, the symptoms start in the first or second decade of life, but not in all cases, so that's less than 20 years of age, and even may present in individuals up to the fifth decade. This is the example of the pes cavus foot, and we see the muscles in the bottom of the foot are comparatively stronger, and so these continue to work as well, and as these get weaker, the foot tends to arch up like that. And this is an example of drop foot, so an individual will have trouble maintaining the foot in that 90-degree position and the foot drops. Balance is affected, and sometimes individuals will have sprained ankles because of the degree of weakness in that area. When nerve function is lost, people can have different sensations or lack of sensation, which is confusing to many people. How do I have both? But because the nerves don't convey the information correctly, you have numbness. Even though you can look down at your feet, you don't see anything there. You can have tingling, you can have burning, many different descriptions of what people experience when their nerves are damaged. Also, some of the complications may involve fatigue, so more work to walk. Breathing difficulties are uncommon but possible, and then curvatures of the spine can occur. This is a photograph of the high-arched foot or pes cavus with hammer toes, and then on the right side is the thinning of the muscles that is most notable below the knees. There are many different types of Charcot-Marie-Tooth disease. They can be broken down in order of genetic type, and then we also group them according to inheritance. And the inheritance pattern that we can identify can help us to determine what type it may be and kind of where to direct our testing. And the autosomal dominant forms on the left, demyelinating type 1, axonal type 2. And then the X-linked is the intermediate form, and on the far right are the autosomal recessive forms. Those may be demyelinating or axonal, and those are termed type 4. In evaluation of neuropathies, we do nerve conduction studies, and that involves an electrical shock to the nerves. I think I just saw somebody jump in the audience. All right, I'm not going to argue. And so when we, that was not the laser button. All right, sorry about that. When we record, what we see on the screen is we see these compound muscle action potentials. And so when we set up, we stimulate here, we record over the muscle, and the nerves are working fine, we'll see these nice, robust responses. And hopefully you can appreciate this response and the size of it there. And then when we stimulate further up, we can get information about the size of the response that occurs a little bit later with normal nerves. When there is axon loss, so these nerves are actually damaged, the end result is what we call our compound muscle action potential is small, and that's represented here. And again, stimulating at another site, that's how we get information about different areas and what's going on in the nerve in that segment. Again, with a loss of the nerves or the axons, the neurons or axons, we'll see not every response comes through, so our compound muscle action potential remains small. In demyelinating forms of CMT, again, comparing our normal when stimulating at the wrist versus stimulating at the elbow, we have nice, robust responses. When there's demyelination, the myelin the little black dots around here is affected, and as a result, we have variability, so we have different speeds, and I think you can probably appreciate that there, but the response is occurring a little bit later. Myelin helps speed conduction. And when we move up further into the arm, we'll see changes where with the myelin loss, the responses aren't getting through, and they're definitely delayed. The conduction speeds are, in a normal individual in the arms, are about greater than 45 meters per second. And in the demyelinating form of CMT, we see conduction velocities or speeds of less than 35 meters per second. There are a number of different genes affected in Charcot-Marie-Tooth disease, and they all have important roles in different areas of function in the nerve. The highlighted ones here are the more, some of the more common ones, and they're all involved in different roles that make your nerves work as well as they do. The proteins, the axon transport, and different makeup of the nerve itself. The most commonly involved genes are listed here, and thank you to Tom Bird, because I stole this from his information. What's interesting in all these different types is they do come in different forms, and we did not initially understand that. As we learn more and more about neuropathy and the genetic associations, we learn there are a variety of different ways that people can present, sometimes even within single families. And these refer to autosomal recessive, autosomal dominant forms, X-linked, and even a number of different types of CMT that have been named according to these genetic mutations before we knew what the gene was. These are some of the more common types of the demyelinating form. So CMT1A is about 70% of individuals with the demyelinating form. And the structure here is to show the myelin wrapping around the axon. CMTX is about 10% of the individuals with demyelinating form. And then the MP0 is CMT1B, and that's about 5%. And briefly, because you'll get wonderful detailed information about this from Lauren, there are a number of different inheritance patterns, and I mentioned this is part of how we sort out maybe who has what. And so in an autosomal dominant form, the affected individual, and in this case, it's the mother, to each offspring, each individual will pass down one chromosome. And so in this case, the mother, it's a kind of a roll of the dice, but about half the time she'll pass down the affected gene. The father's not affected, so he never will. So in the end, half of the individuals will end up probably manifesting the disease. The CMTX is an X-linked dominant form, and it's different depending on which parent, what the gender of the parent is that's affected. And in this case, the father is affected, and so when the father donates, the father determines the gender by giving the X or giving the Y. And in the situation where the affected father gives the X chromosome, then the daughters are affected, and the sons remain unaffected because the genetic mutation is not on the Y chromosome. However, when the mother is affected, again, giving either one of these, the individuals will either get the unaffected or the affected, and in that case, we'll have one effect potential for one daughter and one son. So there's a 50% chance for each gender to develop the disease. And then lastly, autosomal recessive, and this requires the unique scenario in which each individual isn't affected. They carry the gene, but when about 25% of the offspring get both of those mutated genes, they will develop the disease. Half of the offspring will have will be a carrier, but will not manifest the disease. And then a quarter will not have the disease. And this is a cross-section of a nerve, and this is extremely magnified. And what we see here are, these are the axons, and something very specific to CMT1 is we see something called onion bulb formation. And in this scenario, that, and even some of these here, you start to develop this regeneration or remyelination attempt, and it ends up wrapping myelin around, and it has this onion bulb appearance, like multiple layers. Treatments include physical therapy, that's important. And again, you'll have a fantastic talk about different treatments as well. Activity is important, careful activity. Braces such as ankle foot orthotics. Occupational therapy, especially for your activities of daily living, use of the hands. Surgery may be indicated for orthopedic problems most commonly. More to come on that as well. And as of today, there is no FDA-approved treatment that impacts the disease. There has been a positive trial in a combination agent that has been looking at slowing disability or decreasing disability in individuals. And that is the end of my talk, and thank you so much for your attention.